Welcome to this discussion of some of the research that I've been involved in, and for your interest, particularly in the Industrial and Operations Engineering Department at the University of Michigan. My name is Mark Van Oyen. I've been on the faculty here since 2005, and my particular interests emphasize stochastic modeling and stochastic control decision-making. Our research group ends up using quite a lot of optimization and machine learning, some online optimization as well as the online learning portions. So it's become quite diverse. I'd like to show you a PowerPoint and talk through some of the things that I have experienced and done. I'd like to emphasize access to patient care and the patient experience within the health delivery system. The pictures you're seeing on the bottom two are part of the University of Michigan health system, and the one on the left is the main hospital. It's not all fitting onto that screen, but it's a good chunk of it. On the right, you'll see the interior of Mott Children's and Women's Hospital, other hospitals I've worked with. Also featured here, the U of M health system is quite large. The annual revenue is $4.5 billion roughly. So a lot of activity is going on, and there's various facilities in the region here of southeastern Michigan, and some now in the middle of the state and on the west side of the state. And people come from hundreds of miles around for care. Quite a few of them come from hundreds of miles around for care at the U of M system. I'm having trouble getting this to advance. There we go. Healthcare is quite interesting and offers a lot of complexity for so many reasons. And this graph that I borrowed indicates some of the complexity, just a hint. You as a particular individual facing some type of maybe a cough combined with a headache, and you're wondering, should I go to the website, learn something there, treat myself? Should I go see my primary care physician? Is it urgent? I need to go urgent care? Is it even to the point where I need an emergency room visit? There's many, many other aspects. So for the individual, there's lots of decisions, and those are just a few. Oftentimes in medicine, we think of the provider's perspective, the clinician's perspective, and that person is trying to understand your individual characteristics and needs, and in the context of best practices and various diagnostics and all the other specialists that they could bring in to bear on your case, many decisions are at that level. There's also public health decisions surrounding how should we do screening for COVID or hepatitis? What should be our response to innovations in vaccines be? That's another issue. If you are admitted to a health hospital, for example, you could have quite a complex care pathway involving many different clinicians, providers, diagnostics. Perhaps you'll need surgery. Maybe you'll have to recuperate in a post-anesthesia care unit. Maybe then you get transferred to an intensive care unit. You might be in a regular bed. You might need physical therapy or rehabilitation therapy. You probably need follow-up appointments, at least on an outpatient basis. So you can imagine the complexities of delivering those operations with high reliability and in an efficient manner and in a timely manner. Payers and insurance, that only complicates the situation. One of the things I've been very aware of is oftentimes access to a provider, particularly a specialist, maybe you need to see a specialist about say, issues in your digestive system, or maybe severe back pain. Well, oftentimes the service is really provided on a first come, first served basis. And the problem is if you're in acute back pain, not just looking for sort of a routine type visit or something of that nature, but something where perhaps you've just experienced an injury, but maybe the emergency department is not the right place for you. Can the providers actually give access to the most urgent patients? That is the issue of access delay that I'm going to talk about. I was working with an organization, part of the Veterans Administration, caring for former members of the military, and we're trying to improve the way surgical scheduling was done and how the operating rooms were managed. And we noticed that there were types of procedures where patients would wait well over 6 months just to receive that surgery, which was really problematic, I felt. And what we were trying to do was much more subtle and would make smaller changes. And it seemed obvious that they needed more surgeons. And we found that there were certain barriers, such as the fear that the large, very highly ranked hospital that they were next to and from which they got their surgeons, that by requiring more surgeons, they would have to go to other places to get their surgeons, and they worried about ruining that relationship. And so they weren't willing to make those types of changes. Well, that was a brick wall, and moved on from that project to many others. But after some years, I was sad to see that, in fact, this type of a issue was more widespread. In fact, this issue was really highlighted in 6 different states approximately, and Michigan was not among them. And more than 10,000 patients were affected with extremely long wait times. And there was covering up in the data where they were recording wait times incorrectly to make the numbers look good. And so there were long waits faced for large numbers of patients, and estimated at least 200 or roughly 200 deaths occurred due to the waiting. So this was a serious issue, and they estimated it would be hard to fix and cost a lot of money. Well, that's what happens when you let problems simmer for a long time without addressing them. A much, much, much less severe problem was faced by the Mayo Clinic, and it wasn't really about people dying so much, I don't think. But Mayo Clinic is one of the very best hospitals, health systems in the nation, the world, and people come from all over the world for care there. And it was taking many weeks for patients to get in for this type of surgery, this area of surgery called colorectal surgery. And so they asked for some help from us, and we looked at this relatively modest group of 8 surgeons, and they had a lot of business. So wait times were long. And so for patients with cancer needing surgery, those waits are really a problem. And with that long waits, people will start looking for other places to get their care. The way it usually works with surgeries, it's common that a clinic visit is the first thing to happen to establish the need for surgery and various other relevant information. So if the patient does in fact need surgery, they will then schedule a surgery. And it's important that that be with the same surgeon. And so we were looking at how we could set some targets. The chief of surgery there wanted a category of the most urgent that would get their surgery within 3 days, another within 10 days. And one other piece of information is that we developed some a machine learning algorithm to estimate the chances that a pregnant patient would need surgery upfront when we first took the patient on and got their information. So there were a number of factors in determining these priority types, and I won't attempt to go into too much detail, but as you can see, wait time targets of 3 days, 10 days, 20 days, 40 days, and some patients only need a clinic visit. So we're talking about dramatic reductions, generally speaking, in the wait time. And so these 4 key priority types needed a new approach. And so the model needs to consider some randomness in patient arrivals, the fact that we need to schedule an appointment for the clinic visit, that at the clinic visit we'll find out if they actually need surgery, in which case they were determining the surgical appointment at that point in time, but with our approach, we want to make it upfront along with the clinic visit. So there was a lot of, there could be a lot of overtime, particularly to meet shorter access delay targets. So right now, their approach focused on starting with that first visit, the client's visit within the clinic. And so they would look for the surgeon with the earliest clinic availability. And then after the clinic visit, they'd schedule surgery. Part of the problem was this simple approach, and it needed to be more complicated and have some different understanding of how the system worked. So one of the things that we did was we would realize that it was really critical to look at which surgeon could provide surgery within that target time frame. That surgery and finding a surgeon that could meet that, not necessarily the first available, was critical. There's some subtleties too about if you have a person who's unlikely to need surgery, you'd like a big gap between their clinic visit and the surgery visit, because after the clinic visit, you're likely to find that they don't need surgery. Well, you don't want that surgical time to go unused and wasted. So what you want is to have enough time to get another patient with a clinic visit and then use that surgery slot. So there's some subtleties, some intuition that we had to learn, partly through trial and error, about how the system really works. We needed to make progress quickly. So we emphasized the use of simulation and the heuristics that would keep track of a calendar and search that calendar in a structured way to meet a lot of constraints that they had and achieve those access delays. It's a time-consuming approach, but not relative to creating a new theory, for example. Intuition is really important. To make a fair comparison to the old system, we assumed the old system would meet these new deadlines that we've set for the revised system. And so we allow both systems to use overtime as needed to meet those targets. Well, the end result is that through these new methods, there's so much efficiency gained that the amount of overtime that's needed to meet the targets would be dropped in half. That's just one way to capture a sense of the benefits. They ended up desiring, the surgeons wanted something even simpler than what we were doing, which they then implemented and got very, very good improvements from. Of course, from more of a scientific, bigger perspective, we are interested in how can we develop methodologies that could handle more general problems of this nature. And yes, there's stochastic modeling involved. There's an optimization component. There's some issues of time horizons, and that you're not just looking ahead for a little period of time, but for a long enough period of time. So we chose to employ a multi-stage stochastic programming approach to deal with a multi-stage problem where you're looking, say, weeks ahead into the future. And it could also deal with the progressive revelation of information. Every day you find out who's arrived, you find out things like, did the clinic visits yield a need for surgery or not? And we added a rolling horizon component so that every time a day is completed, we add a new day at the end of the time horizon. So we're looking ahead the same amount of time into the future. We're dealing with different types of uncertainty. The one simple assumption for the arrivals would be the Poisson arrival process, which is not a bad idea for this type of a system. Some simple distribution on the need for surgery. And the hard part is to make surgery durations can be hard to estimate, particularly when there's so many different types of cases. So we wanted a system that would be robust to changes in who the surgeons were or how procedures were done, or whether or not they had enough data to really get a good idea of how long a particular surgery took. So we went for a distributionally robust model with respect to the service duration. So a worst case or adversarial outcome on these service times is how the performance is measured. And we only give it some mean, standard deviation, and support for the classes of surgeries, but the distribution that satisfies those three pieces of information could be anything. And that's a lot of opportunities. So in the end, we did create this system and approach that would allow you to actually look at a lot of different systems and not have to go through all the intuition. Does depend to some extent on details and some of the parameters of the system. So it was a nice step forward. It was the first time that multi-stage stochastic programming had been combined with distributionally robust optimization. In fact, that paper just was accepted to the Production Operations Management Journal, which is a really good journal. And some of the other problems I worked on would involve appointment scheduling, predicting how many patients will be in the hospital and how they'll flow through the hospital, how to tweak triage to improve responsiveness of emergency departments, operating room scheduling, how to manage clinical research units, so on and so forth. These are some of the projects I've worked on and had a chance to work with a variety of hospitals, ranging from more community hospitals to some of the most prestigious institutions in the country. And with undergraduates, I teach them senior design capstone courses and how to improve hospital systems through hospital health system projects requested by the hospital. So I hope that this gives you a little bit of a sense of how my modeling interest combined with my interest in healthcare, allowing us to handle these types of problems. So I hope you find our information and the work we're doing here at U of M very interesting, and it'll be an exciting place for you. Thank you very much.